Sir, good evening. सर एक बार स्लाइड शो में इसको डाल दीजिए स्लाइड। यस सर।
रुक जाना। Dr. Shakit, good
Good
evening.
evening, sir.
Dr. Shakit, good
Good
evening.
evening, sir.
गुड इवनिंग गुड इवनिंग
कैसे हैं सर आप?
ठीक ठीक ठीक
सर थैंक यू सर, थैंक यू. आई एम ऑडिबल सर?
यस यू आर
थैंक यू सर. राइट राइट राइट. My slides are not moving, sir.
Sir, I request our Dean, Dr. Kamlesh Tiwari, sir, to bless the occasion with the opening remarks of this respiratory class short certificate course under the banner of Indian College of Physicians. And that's a marvelous job initiative taken by our Honorable Dean. Over to Dr. Kamlesh Tiwari, sir.
थैंक यू डॉक्टर डीपी थैंक यू वेरी मच एक्चुअली वी हैव इन बिटवीन halfway of this short certificate course
Technically, sir is disconnected. Anand,
जी गुड इवनिंग सर.
good evening. Whether sir is disconnected?
यस सर. सर इज
Okay. So once
Anand ji, my slides are not moving. Anand ji, can you help me with that?
Anand, can you help him? Sir, you are muted. Sir, muted. Anand, you can help
Yeah.
him. Yes,
sorry
sir.
for interruption in between but I am very much thankful to Dr. DP and Dr. Saket. Dr. Saket is the doctor who has saved my life.
Yes.
Everybody knows it. And he is here in front of me to deliver a class on sleep. I will request Dr. Saket to go and teach the students regarding sleep and its disorders. Thank you.
Thank you, sir. Thank you,
Dr.
sir.
Saket,
Thank you.
please.
Sir.
Mr. Anand, can you help Dr. Saket in that slide problem?
Right, my slides move make.
So before Dr. Saket sort it out, Dr. Saket is a Director and Senior Consultant, Department of Respiratory and Sleep Medicine, Jai Prabha Medanta Hospital, Patna, Bihar. He has been previously pulmonary consultant in Paras Hospital, Patna, pulmonary consultant, Asian City Hospital, Patna, assistant professor, Indira Gandhi Institute of Medical Sciences, Patna. And he has many awards and achievements and honors in his armamentarium. He got All India rank first in DM entrance exam. Bravo, Dr. Saket. Performed first IBS Patna in Patna TBNA of Bihar. He also received Young Scientist Award in NAPCON Jodhpur 2010. And he has got many publications, many book chapters in Index Journal, 30 invited lectures, conducted many workshops, NIV, and many of which I have also participated, especially sleep disorder. And we are fortunate to have Dr. Shaki, the renowned pulmonologist, today, and let us learn from his experiences in sleep medicine expert. Over to Dr. Shakir.
Thank you very much, sir. Thank you very much for kind introduction. I would request Anand ji to see if my slides are still not moving, sir. So I don't know what to do. I stopped sharing and I shared it again, but still it's not moving. I will do it once more, sir.
सर मैं यहाँ से शेयर कर दूं.
Yes, you
कर दीजिए.
start. Yeah.
एक बार मैं देख लेता हूँ. Yes, please. Okay, it's moving now. It's moving now.
No, sir, your slide is moving.
Yes, yes, thank you. Thank you. So to begin with, I would like to thank Kamlesh Tiwari sir and Dr. D.P. Singh sir for giving me this opportunity. Both have been very, very generous to me and they have supported me throughout my past 8-year career. So very, very grateful for this opportunity, sir. I've been asked to talk about sleep disorder breathing, particularly about obstructive sleep apnea. Now, sleep is very difficult to define. And since it's difficult to define, we will put it in very simple terms. Sleep is a dynamic and regulated set of behavioral and physiological state during which many processes vital to health and well-being take place. Now, it's very important to sleep adequately. People who sleep more than 7 hours are healthier and they live longer than those who sleep less than 7 hours. Sleep deprivation is becoming very common due to current lifestyle, in mobile phones, various screens, which have become more and more personalized, and people spend watching those things in their bed, and it's impacting their duration of sleep. Now, if you do not sleep, there are numerous health problems would come. Sleep, they say sleep is the foundation of all healthy lifestyle. And what are the benefits of sleeping for 7 hours? It will allow cells to heal, it will boost immune system, and it will help our body rest adequately. Heart and cardiovascular system would rest, and it will restore our cognitive function. So sleep deprivation, whenever it happens, there will be immediate and measurable impact on patient's brain. The cognitive decline, sleep deprivation is almost synonymous to being drunk. So cognitive decline, judgment impairment, loss of short-term memory, all these things are very, very common with sleep deprivation, which people do not appreciate immediately. Now, before we go for the OSA, just go through the landmarks in the sleep medicine and sleep science. Now, sleep somehow, unfortunately, has been regarded as passive process till 1950. Now, people used to think that nothing much happened during the sleep when nothing is happening and all sensory inputs quietens down. There's a reduced sensory input to the brain will quiet down and patient will fall asleep, which was far from the truth. Now, in somewhere in 1930, scientists like Hans Berger, they started recording the sleep waves, and they started doing this EEG. And when they were doing it, they realized that in various conditions, when patient is awake, when patient is sleeping, and even during the sleep, we will have different kind of brain wave. But the fundamental change took place when scientists like Arnsky and Kleitman, they identify rapid eye movement during the sleep. Now, this was very paradoxical. While patients supposed to be sleeping, eyes were moving very, very fast. And when they recorded the brain waves during this period, they realized that the brain activity is it's a very active brain waves, which is quite similar to the awake condition. So they were able to identify this REM sleep, and REM sleep is also known as paradoxical sleep. Paradoxical because patient appears to be sleeping, the arousal threshold is much higher. It's difficult to awake patient who's in REM sleep, but yet the brain activity is like as if patient is awake. Eyes are moving very fast. Patient sympathetic activity is slightly on the higher side. Respiration is irregular. Heart rate is kind of irregular. So it was little surprising. And only by 1950, scientists like Dement, they were able to record sleep EEG during whole sleep, and they realized that sleep has got various stages, and they were able to come with the sleep architecture and duality of sleep, and then sleep cycles. And subsequently, the scoring system for sleep and respiratory event was given by R&K, and it was subsequently revised by American Academy of Sleep Medicine, and currently we follow the scoring system given by American Academy of Sleep Medicine of 2012. Now, coming to the discovery of sleep apnea, sleep apnea was very recently discovered. It was discovered somewhere in 1970 by scientists known as Gilliland. And in somewhere in 1980s, they did some landmark studies, landmark epidemiological studies, which was firmly able to establish that OSA has got significant cardiovascular consequences if not treated. Two studies which are worth mentioning is Wisconsin cohort study and sleep heart health study. And these two studies firmly establish that OSA has got significant cardiovascular consequences, which we are going to discuss in subsequent slides. But in early 80s, we did not have effective treatment for sleep apnea. The only treatment which was available was weight loss and tracheostomy, which sounds very radical. So somewhere in 1981, an Australian pulmonologist known as Colin Sylvan, he was able to introduce this CPAP, which works as a pneumatic splint. And now CPAP has become a standard of care for sleep apnea, and more than millions and millions of people are using CPAP. So the prognosis of OSA has changed very significantly. Now, this is the current classification of sleep disorder. So, which is given by International Classification of Sleep Disorder. So we have got 7 major categories of sleep disorder, which is insomnia, which is the most common sleep disorder, followed by sleep-related breathing disorder, central disorder of hypersomnolence, which will include narcolepsy, circadian rhythm disorder, in which we will have shift workers, sleep disturbances, jet lag, advanced phase, early phase sleep disorders. Then we have got parasomnias, including bruxism, sleep terror, sleepwalking, and all those things. Then we have got sleep-related movement disorder, which include restless leg syndrome, periodic limb movement, myoclonus during sleep, and various other sleep disorders. So we are going to focus upon the sleep-related breathing disorder, which can be further classified into central sleep apnea disorder, obstructive sleep apnea, and sleep-related hypoventilation disorder. Among central sleep apnea, we have got famous chain stroke breathing, then central sleep apnea due to periodic high altitude periodic breathing, central sleep apnea due to medications and substances like narcotics, those who are there because of medical reason or recreational reason. And then we have got this very interesting entity known as treatment emergent sleep apnea. Now, what is treatment emergent sleep apnea is that these patients have obstructive sleep apnea, and when we put them on CPAP, ideally it's supposed to abolish their apneic events, but these patients, to begin with, they have obstructive sleep apnea, but on CPAP, they will develop central sleep apnea. And many of these patients, central sleep apnea would persist, and we might have to switch from CPAP to BiPAP ST mode. So these are the central sleep apnea syndromes. And then obstructive sleep apnea, we have got obstructive sleep apnea in adults, obstructive sleep apnea in pediatric. And then we have got this hypoventilation disorder, in which we have got this infamous obesity hypoventilation syndrome and congenital central alveolar hypoventilation syndrome. We will talk about OHS subsequently in the slide. This congenital central alveolar hypoventilation syndrome is pretty rare, seen in newborn. They won't be breathing adequately. They would require some sorts of respiratory support. It's because of mutation of FOXP2B gene. And then again, we have got hyperventilation due to medications like narcotics. And then we have got this interesting segment, which is sleep-related hyperventilation due to medical disorders. Now, what are medical disorders we can think of which will lead to hyperventilation? We have got restrictive disorders like kyphoscoliosis. Then we have got the neuromuscular disorder like myasthenia gravis, amyotrophic lateral sclerosis. Since we won't be talking about the sleep-related hyperventilation due to medical disorder in subsequent slide, I would just like to speak something about these patients. So any patient who has got neuromuscular weakness, and if he has daytime hypercapnia, if he has nocturnal desaturation and saturation goes below 88% for more than 10 minutes, if his FVC is less than 50%, and if his negative inspiratory pressure, he's not able to generate negative pressure more than 60 centimeter of water, he should be supported. Otherwise, he will develop profound respiratory failure, which could be life-threatening. So these patients have to be screened. We have to remember 4 things: FVC below 50 and IF less than 60. Patient is having hypercapnia and hypoxia during sleep. These patients have to be supported via giving a BiPAP support during sleep. Now, sleep is earlier people used to think it's a passive process, but a lot of things happen during sleep. Brain activity would change during the different phases of sleep. And typically we classify sleep into 4 stages: stage 1, stage 2, stage 3, and REM sleep. Earlier we used to call stage 1, 2, 3, 4. Now 3, 4 has been merged together as stage 1, 2, 3. And then we will have REM sleep. Now REM sleep tend to be more common during the later phase of the sleep, that is early morning. And delta wave, which comes during stage 2 and 3, particularly in stage 3, used to be more common during the earlier part of the sleep. And this will come in the cycle, which will be of 90-minute cycle, and usually 3 to 4 or 4 to 5 cycles of these different phases would take place. So same thing, let's not repeat. So in stage W, what happens? It's the earliest stage of sleep, when a person is feeling awake and switching to drowsiness, falling asleep. He may experience strange and vivid sensation called hypnagogic hallucination. And common examples include feeling like when you are falling or hearing somebody call your name. Now, stage W will be characterized by alpha rhythm, which is 8 to 13 hertz wave. They will be having most of the time, they will occupy the most of the epoch. In stage 1, it's a transitional stage from wakefulness to sleep. Brain and body will begin to relax. Few jerking and twitching movements may occur. Patient is easily arousable, has low threshold, and most people will spend just few minutes in stage 1. Stage N2 is the largest segment of sleep. Here, the breathing and heart rate will slow down and become regular as body further relaxes. It will last around 10 to 25 minutes in different cycles, and 50% of the total sleep cycle. N2 stage will be characterized by presence of sleep spindle and K complexes. And N3 is slow wave sleep or delta wave sleep, which is which is of the frequency of 0.5 to 2 hertz per second. Lots of restorative biochemical process would occur. Patient will have high threshold for arousal. It will be difficult to wake him up from the sleep, and it will last for 20 to 40 minutes and occupy like 20 to 25% of total sleep time. And REM is the paradoxical sleep. The why paradoxical? Once again, we will go through because brain seems to be active. The brain activity is like of light sleep, awake. Then you would have rapid eye movement. Usually in N1, N2, N3, the eye movement will be absent. It will be slow roving eye movement, but here eye movement will be very rapid. Dream would take place during this stage. Usually occurs roughly every 90 minutes. Progressively increase in duration throughout the night. That is, it's more in the early morning or later phase of the sleep rather than in the first half of the sleep. Occurs after stage 3 in the first part of the night, but may sometime happen after the stage N2, and it accounts for 20-25% of the total sleep time. Now, a few interesting things which will happen in REM sleep, that patient will become pyroglyothermic. That is, temperature regulation will be lost. A patient will also develop a profound hypotonia. And why does it happen? Because nature does not want, let's say, when we are dreaming, and if we are going to enact our dream, we can injure ourselves. So there will be locus coeruleus mediated atonia of all the muscles, so that we do not enact our dream and we do not injure ourselves. So this is the sleep structure. Stage 1 and 2 will compromise around 50%. Stage 3 will be 20%, and REM will be 20 to 25%. Cycle length is usually 90 minutes, may vary from 80 to 110 minutes, and there will be 4 to 5 cycles during the night. So what happened in the sleep? Because we are going to talk about OSA, first we need to understand what happens during the normal sleep. Then only we can understand the what is the impact of OSA on the normal sleep, and how does it impacts the our health of various body systems. So central nervous system, there will be increase in parasympathetic tone and decreases in sympathetic tone. Now this parasympathetic tone is very, very important. You know, what happens when there is an increase in parasympathetic tone? The heart rate will come down, the blood pressure will come down, body will be much more relaxed, and sympathetic tone will do the reverse of it. So there will be decrease in heart rate, decrease in cardiac output, and blood pressure would fall by 15 to 20%. Now that normally happens, but in OSA patient, it does not happen. OSA patient, that sleep-related fall in blood pressure won't happen. Regarding ventilation, ventilation will decrease mainly due to decrease in tidal volume and decrease in ventilatory response to both hypoxia and hypercapnia. So what would happen because of this? Because of this, there will be some rise in PCO2. Let's say a patient awake PCO2 is 37, there will be rise of 4, 5 mm, 6 mmHg of PCO2. So during sleep, it will go up to 43, 44, but it won't be more than 10, because if it is more than 10, then we say that there is a sleep-related hypoventilation. In gastrointestinal system, there will be decreased salivation, decreased gastric acid production, and a decreased gastric emptying. And many hormonal changes would take place, particularly the growth hormone. Growth hormone, the maximum amount of growth hormone secretion takes place during the first cycle of sleep cycle, particularly in the N3 stage of the sleep. So if the sleep is compromised, so many hormonal imbalance may happen. Also, sleep-related decrease in GFR will lead to decreased urine production, and that's why during sleep, most of the people who are healthy, they will not be going to washroom. Anybody who's going to washroom after sleeping more than twice, we call it pathological nocturia. So I think I will skip this. So coming to OSA, OSA is a sleep disorder that involves sedation or significant decrease in airflow in presence of breathing effort. It is the most common type of sleep disorder breathing, and it is characterized by recurrent episode of upper airway collapse during sleep. Now, how do we define apnea? Apnea is cessation of airflow by at least 10 seconds. So we have to remember this duration. Apnea, there won't be any airflow because of airway collapse, and this cessation of airflow has to be last for 10 seconds. In definition of apnea, we do not have any saturation criteria, unlike hypopnea. Now, hypopnea is defined as that there is a recognizable transient reduction of breathing for 10 seconds or longer, and this decrease is of magnitude of more than 30%, and which is associated with 3% fall or arousal. So you have to remember this, that the duration has to be last for at least 10 seconds, and the amplitude of breathing has to be fall more than 30%, associated with 3% fall in saturation, or there is arousal associated with this decrease in amplitude of breathing. So this is hypopnea. Now, hypopnea is apnea. There never been any debate, but when it comes to hypopnea, we had different rule earlier on. So those who have read in the past, older rules say we had two definition of hypopnea, and it was more than 30% drop in amplitude, which is lasting for more than 10 seconds, and 4%. Currently it is 3%, but earlier it was 30% decline in amplitude and 4% decline in saturation. And we also had alternative rule earlier on, which was 50% amplitude drop with 3% desaturation, which is lasting for more than 10 seconds. But now these rules have been changed, and we have made it somewhat simple. there is a decline in amplitude by more than 30%, which lasts for more than 10 seconds, and more than 3% oxygen desaturation. And then we have got another event, which is known as respiratory effort-related arousal. Now, here it is characterized by increasing respiratory effort for more than 10 seconds or longer, leading to arousal from sleep. But it does not fulfill the criteria for hypopnea or apnea. That means there is no desaturation and there is no decrease in amplitude by 30% or so. So how you would identify this? So normally what happens whenever we have that monitoring system using nasal cannula, what will happen normally if there is no airway limitation during breathing, you will have a rounded shape, curved tracing. But when there is a airway resistance, airway limitation, the rounded shape will be curtailed and it will become flatter. So if it is getting flatter, it is suggestive that there is an increased effort and airflow limitation is there, even though it is not meeting the criteria for hypopnea or apnea. Ideally, what's supposed to be done? Those who have a very advanced lab, they use esophageal pressure monitor, and they will be able to measure the effort using esophageal pressure monitor. And if there is a negative increase in negative pressure in esophageal pressure monitor associated with arousal, they will mark that event as a respiratory effort-related arousal. Now, this apnea and hypopnea can be classified as obstructive and central event. Now, how do we identify the obstructive event? I will show the tracing subsequently in our presentation. But when there is when we call it obstructive event, we call it obstructive event when patient is making effort to breathe, and yet there is no airflow. So if there is a complete airflow cessation, we call it obstructive apnea. If this is a partial airflow compromise, we call it obstructive hypopnea. So you will be able to, if you do PSG, you will be able to see that there is a limitation of airflow or cessation of airflow, but abdominal movement and thoracic movement is going on, suggesting thoraco-abdominal effort, but there is a airflow compromised. So this is obstructive, but central events are different. Here there is a cessation of flow. At the same time, patient is not making any effort to breathe. So there is lack of thoraco-abdominal effort and there is a lack of airflow. So we call it central. Now something is known as mixed event. Mixed events are a little bit complicated. Here they will have both the component, obstructive and central component. It will begin as central apnea or hypopnea. And in subsequent phase, the later part of the event, this abdominal thoraco-abdominal effort would appear. So we call it mixed event. So one would like to think, why does it happen? Why it's happening? Because these patients, because of certain structural reason, have a compromised upper airway. The location of obstruction is usually retropalatal, that is behind soft palate, or retroglossal, that is behind the tongue. Now, this is the area where the bony framework is not very strongly supported. So they tend to collapse. Now, if there is a mild compromise, there will be vibration of, there will be some turbulence in airflow, there will be vibration of soft palate, and it will be only, there will be only snoring, but there won't be any airway limitation. Then we have got upper airway respiratory UARS resistance syndrome. Upper airway resistance syndrome, in which is almost events which are that rare events are there, but there is no hypopnea or apnea, in which the compromise of airway is little bit more, so that patient is able to maintain saturation. Patient is able to breathe enough so that he's maintaining saturation, but now he has to make more effort to breathe. So, and because of that, he is being aroused and sleep is getting fragmented. If it worsens further, then it will lead to hypopnea. And if there is a complete cessation of breathing because of airway compromise, it will lead to apnea. So we can think this disease as a continuum of progressive increase in airway compromise And the worst form being the obesity hypoventilation syndrome, in which patient is very, very obese, which is leading to a lot of loading on the respiratory muscle, and respiratory muscles are not able to cope with this excessive workload, and they start hypoventilating. So coming to the epidemiology of these obstructive sleep apnea. So once again, we have to go back to those landmark epidemiological studies, Wisconsin study and sleep heart health study. Now, in Wisconsin cohort study, they were when they took AHI more than 5 as a cutoff. So the prevalence of SDV was 9% in women and 24% in men. Now, if you take AHI more than 5, but along with symptom, that is OSA syndrome, that you have AHI more than 5, you have OSA, but you also have symptom, because significant proportion of these patients will not have symptom like daytime fatigue, daytime sleepiness. Then the prevalence will fall to 2 to 4% in women and 4 to 9% for men. Now, even if it is 2% of adult population or 4% of adult population, the absolute number becomes huge. And unfortunately, SDV remained undiagnosed in approximately 93% of affected women and 82% of affected men. Now, a few years back, in India, whatever studies had been done, they have put that in India, we have got around, when it comes to HI more than 5, we will have around 52 million people suffering with mild OSA. And if you take cutoff of 15, you would have 29 million people, adult population suffering with OSA. A recent study from our center, Safdarjung and AIMS, they have shown that around 104 million Indians of working age suffer from OSA, of whom 47 million have moderate to severe OSA. Why they tend to separate this moderate to severe OSA? Because these people are at worse cardiovascular outcome, at the risk of worse cardiovascular outcome. Mild OSA, we do not have evidences are not as strong that they have significant cardiovascular consequences. When it comes to moderate to severe OSA, it's unambiguous that they do have cardiovascular consequences. And this represents a major public health problem in India with important implications for global burden of disease. Now, what are the risk factors? Now, probably the most important risk factor in current scenario is obesity. Now, obesity is directly related to OSA. Somebody who gains around 10% of weight, their AHI tend to increase by 32%. And if you lose 10% of weight, there will be 26% reduction in AHI. What happens whenever patient is obese? There will be some fat deposition in the pharyngeal area, in the tongue, in the lateral pharyngeal wall, and it will lead to the airway luminal compromise and make it more prone for airway collapse during sleep. Again, when it comes to different sexes, male are almost twice the time more commonly they tend to have OSA compared to female. We don't know why exactly it happens, but probable explanation for this is that male have longer airways, and which makes it more collapsible compared to female. Now, coming to age, the prevalence of OSA would increase from age of 40 to 60. And this is the time, this is probably the most productive part of the time. And here, the prevalence of OSA will increase. In elderly, let's say after 75, the rise in incidence of OSA becomes less and less. So this is the middle age of 40 to 60 is the time when most of the people will develop OSA. Postmenopausal women have almost 3.5 times more chances of having OSA compared to premenopausal women. When it comes to ethnicity, blacks have more chances of having OSA compared to white. Asian people, because of their facial construct, are apparently more prone to have OSA compared to white people. Alcohol will alter the sleep architecture. It will make REM smaller. and it will also increase the aerosol threshold. So if somebody is going to have apnea because aerosol threshold is high, he will have longer apneas and make OSA worse. When it comes to hormonal abnormality, hypothyroidism is important, and it can cause OSA by various ways. It can lead to upper airway myopathy, a very subtle myopathy. There will be mucoprotein deposition in the pharyngeal wall, making it less roomy. And they might also cause abnormality in ventilatory control, making the ventilation unstable and more prone for developing OSA. Acromegaly, again, they would have large tongue, which may lead to OSA. Now, this is a very interesting image. A normal healthy person with, in comparison to obese patient who known to have obstructive sleep apnea. Now, what you can appreciate here that this man has lots of fat deposition in the subcutaneous area. He also has much bigger tongue with the good amount of fat deposition as those white streaks are seen. His airway is much more compromised. His palate is soft palate, particularly is bit longer, making it more collapsible. So this is the kind of picture, and this is the impact of obesity would be there on upper airway, making it more collapsible, less roomy. Now, who are the patient population who are at very high risk of OS? What I mean to say that when you see these people, you should actively screen for OS. So anybody who has BMI more than 30, they are at high risk of OSA. They should be screened. Now, resistant hypertension, anyone who is taking more than 3 antihypertensive medication and yet not able to have adequate control, and if you're not having any other explanation, strongly look for obstructive sleep apnea. Lone atrial fibrillation, somebody who's developing atrial fibrillation without any obvious cause, doesn't have any valvular heart disease, doesn't have any obvious CAD, and yet developing atrial fibrillation, you have to think of obstructive sleep apnea. Again, those patients who undergo cardioversion and relapse, again, you have to think in terms of obstructive sleep apnea. Anybody with nocturnal arrhythmia, you have to think in terms of obstructive sleep apnea. CHF will have a very different kind of, patients who are having CHF, they are prone to develop obstructive sleep apnea. They are also prone to develop this periodic breathing, that is chain stroke breathing. Now in CHF, we have got diastolic heart failure and the heart failure with preserved ejection fraction, heart failure with reduced ejection fraction. Anybody who has heart failure with preserved ejection fraction, you have to screen for obstructive sleep apnea, apart from treating other comorbidity like hypertension, CAD. CVA patient will, OSA will make patient more prone to have CVA, and CVA patient will have high chances of having obstructive sleep apnea. Anyone who has unexplained pulmonary hypertension, because of OSA, there will be repeated cycle of hypoxia, which will lead to pulmonary vasoconstriction. And when it's happening for decades together, they might develop pulmonary hypertension. Any high-risk driving population in USA, it's very common, and they are very, very strict. Those who are professional driver, truck drivers, if at all they have any symptom, they have to undergo a sleep study and they have to be on treatment. And anybody who is going for bariatric surgery, polysomnography and screening for OSA has to be done. Now, coming to the symptom, a patient family will be able to tell you certain behavior pattern in this OSA patient. Most common being snoring. They will usually have loud snoring. They will be they would have been snoring for years together. This snoring might be disruptive to the bed partner. Witnessed apnea, where in between the snoring, as if patient is not breathing, and very often family, spouse, bed partner is able to narrate the incidents. Gasping and choking sensation during sleep. Many patients will say that they wake up all of a sudden gasping for breath. Nocturia. Why does nocturia happen? Because of two reasons. Normally, what happens whenever patients would sleep, there will be a decline in GFR and less urine formation, which does not happen in these OSA patients because they never go in deep sleep because of recurrent apneas. And also because of apnea, there will be increased secretion of atrial natriuretic peptide. So there will be increased urine formation. And anyone who has more than anyone who has to wake up twice more than 2 times during sleep, we call it pathological nocturia. Few patients might complain of insomnia. Few patients might complain that they are restless. Our spouse may complain they are restless during sleep. In daytime symptom, because of frequent awakening and fragmentation of sleep, they will have typically non-restorative sleep. They will wake up tired. You might have morning headache, dry and sore throat, excessive daytime sleepiness, daytime fatigue, and cognitive decline, short-term memory loss, intellectual impairment, poor concentration. All these things will happen. They might also have decreased vigilance, morning confusion, personality and mood change, including depression and anxiety. Particularly women often present with depression when they have OSA, sexual dysfunction, including erectile dysfunction and poor libido, gastroesophageal reflux, resistant hypertension, and other things. Now, excessive daytime symptom is one of the most difficult symptoms. It will reduce quality of life, impair daytime performance, cause neurocognitive deficit. And how do we assess the sleepiness? So we have this Epworth sleepiness scale. It's a questionnaire which determines that what is the tendency of falling asleep for a patient given 4 day-to-day, 8 day-to-day, a different situation. So this is Epworth sleepiness score, in which you will have a maximum score of 24. You will be given 8 different situations where you will tell about probability of dozing off on the scale of 0 to 3. And maximum score is 3 into 8, which is 24. And anybody who says that anybody's score, when the score is more than 10, we call patient is abnormally sleepy. So ESS score of 11 is associated with greater propensity to fall asleep on the multiple sleep latency test. ESS is useful for evaluating response to treatment. And if treatment is effective, ESS score should decrease with time. Now, we do not have, this is a very interesting chart. We do not have a very strong direct correlation between severity of sleep apnea and OSA. However, ESS. However, with severity of worsening OSA, ESS tend to go higher. But if you see the range, even in the severe OSA, there are patients who are scoring only 8. So a good number of patients, even though they have severe obstructive sleep apnea, may not report that they are sleeping. So ESS being it's a good, useful tool, you cannot rely solely on ESS. If you have high suspicion of OSA, you go ahead and do the test, even though patient is not complaining of excessive daytime sleepiness. So this is what we want to say. The correlation is there, but the correlation is weak. And different people have different susceptibility to OSA, and they will present differently. Not everybody would complain of excessive daytime sleepiness. Few will be able to function pretty good, but they might also have, even then they might also have a pretty significant OSA. Again, this we have got another questionnaire known as a stop bank. Very simple questionnaire, very easy to use questionnaire. We use it in our clinic. You have got 8 questions for which you have to say yes or no. And questions like, do you snore? Do you feel tired? Whether anybody has observed, do you have any witnessed apnea? Do you have hypertension? If BMI is more than 35, age is more than 50, neck circumference is more than 40, and gender is male. If answer is yes, to more than 3 questions, there is a high risk of obstructive sleep apnea. If answer is less than 3, the risk of OSA is low. However, if you have high clinical suspicion of OSA, despite these scores, you can go ahead and do the test. These scores have good sensitivity, but their sensitivity is to the tune of 80 to 90%. And considering the number of patients, huge burden of OSA, you will still miss significant amount of patients if you rely only on the score. However, they do help us to select the patient that predict the possibility of OSA. When it comes to physical examination, I mean, we have to look for a few things. Whether BMI is more than 30, a large neck circumference. If neck circumference is more than 17 inches in men and 15 inches in women, it predicts the possibility of OSA. Ballampati score is very, very important. We use modified Ballampati score, which we are going to show you in next slide. Narrowing of lateral airway wall, enlarged tonsil. If there is any maxillofacial abnormality like small jaw, retrognathia, macrognathia, high arch palate, all these things will make patient more prone to develop OSA. Now, this is modified Ballampati score. Ballampati score is being used by anesthetist for assessment of difficulty of intubation. There they ask to protrude the tongue. Here in modified Ballampati classification, we simply ask patient to open the mouth, and it will give us some basic idea how crowded the airways are. In grade 1 or class 1, you will be able to see the whole of soft palate and entire uvula would be visible. In class 2, soft palate will be visible, but only part of uvula will be visible. In this, class 3, only the base of uvula will be visible, and in class 4, even soft palate is not visible. And as the severity becomes worsened, the possibility of OSA is much more likely. It says that airway is very, very crowded. Upper airway is very, very crowded. This is an example of retrognathia and how it's going to compromise the airway. Anatomic factors causing upper airway crowding is enlarged tonsil, particularly in enlargement of tonsils and adenoid will lead to a pediatric OSA. Macroglossia can lead to OSA, increased soft tissue, lateral pharyngeal wall. Length of soft palate, longer the soft palate, more probability of collapsibility, higher the probability of collapsibility, and abnormal positioning of maxilla and mandible. As I have said earlier, the site of obstruction can be retropalatal, that is behind soft palate, retroglossal, behind tongue, or even hypopharynx. Now, coming to the pathophysiology, what's happening because of OSA? So, whenever there is a recurrent episode of apnea, two things are happening. Sleep is getting fragmented because of erosion, and depending on severity, this can be up to 100, 200, 300 times during the sleep. So patient is not getting consolidated sleep. And because of this, there will be daytime sleepiness, accident can happen, there will be poor quality of life, and there will be neurocognitive decline. Then there will be a repeated episode of hypoxia, correction of hypoxia, hypoxia, correction of hypoxia. And every time the airway is obstructed, a patient is trying to breathe against closed upper airway, making huge effort, creating huge negative intrathoracic pressure. And this will lead to sympathetic surge, lots of symptomatic effect on cardiovascular symptom, oxidative stress, inflammation, various inflammatory pathway will be activated, which will lead to endothelial dysfunction, hypercoagulability, and endocrine dysregulation. And overall, eventually, it will lead to resistant hypertension, more chances of cardiovascular symptom, more chances of heart failure, particularly diastolic heart failure, make patient more prone for arrhythmias, CV, and pulmonary hypertension, and insulin resistance. My slides are not moving. Excuse me. Okay. So, so now many would think that probably we are overstating when it comes to OSA and cardiovascular consequences, OSA, its impact on mortality, but it is not so. Now, once again, we would go back to those landmark studies, Wisconsin sleep cohort, and what we see that those patients who have severe OSA, the hazard ratio of is almost 4 times compared to those who have who do not have any OSA. These plottings are very obvious. Those who have OSA do not have OSA or have mild OSA, and there is a clear-cut dose-response relationship. Higher the severity of OSA, the lesser people are surviving. So let's not think that we are overstating when we talk about cardiovascular consequences. This is well beyond a doubt. Now, coming to OSA, and because of decline in neurocognitive function and excessive daytime sleepiness, these patients are highly prone to develop or have road traffic accident. Slides are not moving. Okay. So, so sleep deprivation and impaired cognition because of OSA will lead to poor response time, which may be very, very important in avoiding accident. So again, these patients are very at higher risk of developing having road traffic accident. And when we treat these patients with CPAP, the probability of having road traffic accident goes down significantly. This may not be important for everyone, but particularly those who are professional drivers, truckers, for them it becomes very, very important because otherwise it's a very important public safety concern. Now, what are the indexes we have for sleep disorder breathing? So we have got apnea-hypopnea index, where we calculate the number of apnea and divide it by total duration of sleep and make it AHI per hour. Respiratory disturbance index, here they will add apnea-hypopnea along with, they will also add respiratory effort-related arousals, that is RERA, and divide by total duration of sleep. Now, what are diagnostic tests which are available? Now, this is, I think, important. Now, gold standard for diagnosing any sleep disorder breathing is attended PSG type 1. Here, what we do, we have we would be able to stage sleep along with body position, leg movement, and respiratory channels. So we will have minimum of 7 channels, which will include EEG, EOG, EMG, ECG, airflow, respiratory effort, and oxygen saturation. Now, EEG, EMG, and EOG are neural channels which will help us define sleep, study various kind of waves so that we know that which stage patient is in, whether it's a REM sleep, non-REM sleep, whether it's N1, N2, N3. The same thing when we do where we don't have a technician, we call it unattended type 2 PSG. So everything will be same, but here in type 1, we are doing all this thing in presence of a technician. who is continuously monitoring the recordings overnight and can intervene. Now, type 3 is home study or portable sleep study, which most commonly being done in our setup for our patients. Now, it will include minimum of 4 channels, including ventilation, at least 2 channels for respiratory movement and airflow, and then 2 channels for heart rate, oxygen saturation. Body position is possible. We can make out that patient is in what position. There is a supine, he's in right or left decubitus. But since it's unattended, personal intervention won't be possible. And then we also have a very simple kind of study, which is single or dual channel, where we will only have airflow and oxygen saturation. So, but the gold standard is PSG-1. Other type like home studies are also useful, but where we can do home studies and where we should avoid those studies, home studies, we will be discussing subsequently. So in lab with all possible channels, EEG, EMG, EOG is type 1. Same thing, which is not in presence of technician, is type 2. Simpler studies where we use only airflow, oxygen saturation, and thoracoabdomen welts, which will measure the respiratory effort, is type 3. Type 4 is where we are using only airflow and oxygen saturation. And we have got a new kind of test also available, which will be based on peripheral arterial tonometry, one sleep test by ResMed, and I think equivalent also, Philips has also got one equivalent of this. Now, where are we supposed to, we will come back on this. Now, where you should do type 3 studies, that is a home test, and where the type 1 would be better. This is the very common question because we do not have access to type 1 most of the time. Only few centers are offering type 1 level 1 PSG. So we need to know that which patient is suitable, where we can refer them to a proper sleep lab which does type 1, and which patient is suitable for type 3. Because type 3 is more cost effective. You can do it at home. It's much cheaper. So if you have high pretest probability of OSA and you do not have any significant comorbidity, then you can go for type 3 study. That means you've got an obese patient who has typical snoring, has witnessed apnea, complaints of daytime sleepiness, but does not have any heart failure, any neuromuscular disorder, any other disorder. So these patients is suitable for type 3, where you will be able to document obstructive sleep apnea by level 3. But if somebody has congestive heart failure, somebody has got kyphoscoliosis, somebody has some other neuromuscular disorder, somebody has got some neurological disorder, these patients, they are not suitable for type 3. So these patients have to undergo type 1 study. So what is the diagnostic criteria for OSA? The diagnostic criteria that patients should have excessive daytime sleepiness, which is not explained by other factor. You should have 2 or more of the following that is not explained by other factor, that is choking, gasping, frequent awakening, poor sleep, daytime fatigue, impaired concentration, along with PSG, where they have shown that AHI is more than 5 or more than 30 events per 6 hours of sleep. So this is the diagnostic criteria for OSA. Now, what is a workup? Before that, we will go for, so in a patient with OSA, what are the typical findings we would have? So typically these patients will have frequent awakening, so there will be increased wake after sleep onset. And since they are not able to go into deep sleep, because every time they go into sleep, they will develop apnea and arousal. So there will be longer stage 1, and there will be reduction in the stage 3 and stage R. And there will be frequent respiratory erosions. Respiratory findings will be, they will have a continuous snoring, a lot of snoring. They might have different kind of apnea, obstructive, central or mixed apnea. AHI, which is 5 to 15, is considered to be mild. If it is 15 to 30, it's considered to be moderately severe. And if it is more than 30, it is considered to be severe. Then we have also got AHI supine. Now, there will be few patients who will be having much more events, respiratory events, when they are lying down on their back, that is supine. But when they switch to lateral decubitus prone posture, their AHI will significantly fall. So we call it postural OSA, and we call it when AHI supine is more than the AHI, more than twice than the AHI non-supine. Then again, when people are more likely to develop severe apneas. So normally the most severe apneas, most severe event will happen in REM sleep. Why it will happen? Because REM is associated with muscle hypotonia and because of and high aerosol threshold. And because of that, the apneas in REM will be more longer, more frequent, and more severe. So anybody who has AHI, much more high frequency of events in REM sleep compared to non-REM sleep. So we will say he has REM predominant events. And then we have to also look for lowest saturation once again will be in REM sleep because of the same thing, because they have higher threshold. They will develop severe desaturation, more severe desaturation during the REM sleep. I think I'll skip this. Workup. So workup, normally blood test we do not perform routinely. I mean, those who are at high risk of hypothyroidism, we have to look for thyroid testing. It depends upon patient comorbidity that what blood test we are going to perform. Otherwise, OSA per se does not require any significant blood work. So what all things we are going to look into, let's say we have a level 1 PSG and we have got a report, what all things we're supposed to look for? We're supposed to look for sleep efficiency. Sleep efficiency is calculated as if after light out and light on. What is the time duration patient has actually slept? Once we have switched off the light and till we switch on the light, so total recording time versus the actual sleep time is sleep efficiency. So, and again, we have to look for sleep latency and REM latency. What is the sleep architecture? As I said earlier, usually in OSA patient, N3 and REM will be lesser because they are not getting into deep sleep. And what is the AHI? What is the RDI? What is the arousal index? How frequently patient is waking up? What is desaturation index? What is the duration of period in which saturation is below 89%? Now, when we look into different things, and when we correlate these things with cardiovascular consequences, so this what has been shown that the degree of hypoxia and severity of hypoxia correlates most closely with the cardiovascular consequences. So a patient who has severe hypoxia during sleep and spending a lot of time having saturation below 89 is much more likely to have cardiovascular consequences compared to somebody who has similar AHI but does not have that degree of desaturation. And we have to also look for predictive movement, and level 1 PSG will also record ECG throughout the night, so we can look for various arrhythmias. Now, this is the classical typical tracing of PSG1, in which you will, on the top in the blue tracing, we have got EOG. Below that, we have got EEG. And then we have got mic and nasal cannula and thermal sensors for flow. So what you are able to see here, the red arrow is showing that for almost like more than 30 seconds, patient was not breathing. There is no flow. But below, you can see that thorax and abdomen, the efforts, patient is making effort, but despite effort, patient is not able to breathe because of collapse of airway. So this is an example of obstructive sleep apnea. So patient is having adequate effort, but patient is yet not having any airflow. Now, this is example of central sleep apnea. Now, you can see pad flow in the red and thoracic and abdominal movement in the blue. And you see here, unlike obstructive event, what's happening that there is apnea, there is absolutely no flow for almost 30 seconds. And then at the same time, patient is also not making any effort. There is no abdominal or thoracic movement. So patient is not having, there is apnea, there is an absence of airflow. At the same time, patient is not making any effort. So this is central sleep apnea. And here, this is the example of mixed apnea. You can see the flow is missing. And to begin with, there is hardly any effort. But subsequently, during the period of apnea, patient will make some small effort. So this is example of mixed apnea, which will begin as central and turn into obstructive event in the later half. Again, here is the example of hypopnea. Those pink bars, which is there on the screen, they you can see that compared to previous tracings, there is a reduction in airflow. And it is associated with desaturation. You can see that just below it, the saturation is 95%, but as you go after a few seconds, the saturation has fallen to 92%. So 3% decline in the saturation and more than 30% reduction in the airflow. So these are the examples of hypopnea. So you can see this is the typical tracing of level 1 polysomnography. I'll just explain a few things. On the top, you have got EOG channels, left and right eye. Below, you have got 4 EEG channels in the pink, F3M2, C3M2, C4M1, O2M1. And then you have got EMG, which is measuring the muscle tone at the chin. Then you have got mic recording the snoring. And then you have got two kinds of flow. A thermal sensor, which will measure both nasal and oral flow, and a nasal cannula flow. And then you have got belts, thoracic and abdominal belt, which will record the thoracic and abdominal excursion and talk about effort. Then you have got SpO2, pulse, body position, and then few labs will use EtCO2 or transcutaneous CO2. Then you have got ECG, respiratory rate, plethysmography. Then you also got EMG channels from the leg, so that we can record the leg movement. And then you have got CPAP, IPAP. So if at all you are going for titration, this will be displayed over here. So this is the typical recording, and you get a huge data from the level 1 PSG. Example of hypopnea with arousal, I will skip this. And this is example of respiratory effort related arousal. So score RERA if there is a sequence of breath lasting for more than 10 seconds, characterized by increasing respiratory effort, which we tend to measure by esophageal pressure monitor. If that is not available, as a ad hoc, we can use that there is a flattening of inspiratory portion of nasal pressure waveform leading to arousal. So you can see the upper tracing. Earlier, the tracings were round, but where the dotted line has been drawn, you can see here the tracings have become flattened, which suggests that patient has got airway limitation. So severity 5 to 15 is mild, 15 to 30 is moderate, and more than 30 is severe. We have also got split night study where we do a diagnostic test in the first half, and then we can, in the same sitting, we can do the titration part. For that, you need to have adequate number of events before you go for titration. So anybody who has got more than 40 events during the first hour of first 2 hours, they can go for titration straight away. Now, portable monitoring we have discussed, so we will skip this. Again, we are going to go for, because I feel this is important. So before you go for portable monitoring, that is home testing, it must be combined with a comprehensive sleep evaluation. Patients should have high pretest probability of moderate to severe OSA. He should not have any comorbid medical condition like COPD with respiratory failure, CHF, or neuromuscular disorder. No clinical suspicion of any other sleep disorder like central sleep apnea, narcolepsy. Patients in whom lab PSG is not possible because of certain medical logistic reasons. And it should not be used for screening asymptomatic population or epidemiological studies. Now, coming to the treatment. Now, we have got mild, moderate, severe OSA. I mean, CPAP is the gold standard for moderate and severe OSA. In mild OSA, we can go for a few other things like upper airway surgery or oral appliances. But those patients with mild OSA who are symptomatic and not willing to use oral appliances or upper airway surgery, once again, CPAP will be the treatment of choice. Now, conservative non-surgical treatment, we have got weight loss. Earlier, it has been said that if there's a 10% reduction in weight, will lead to 26% reduction in AHI. Avoid alcohol just before the bedtime. And if one of the simplest thing one can do that instead of lying supine, one can sleep on the sides and reduce the AHI to some extent and help as an adjunctive form of therapy. Nasal CPAP is an active form of therapy for OSA. It will increase the caliber of airway in the retropalatal and retroglossal region, working as pneumatic splint. It will increase the lateral dimension of upper airway and thins the lateral pharyngeal wall. It will maintain the upper airway patency during sleep, preventing the soft tissue from collapsing. Now, this is a very interesting MRI image. A same patient, before application of CPAP, you can see the airways are very compromised. And once you apply a CPAP of 15 centimeter, airway become much more roomy and they are much less likelihood of collapsing during sleep. Similar thing on different airway pressure, you can see the airways are getting widened and chances of getting collapsed and airway limitation would be much lesser. These are different kind of mask interface we have. We have got nasal pillow, nasal mask, or full face mask, depending upon patient condition, we can use them. So all patients who have got AHI more than 15, they should be using CPAP. Those who have got AHI 5 to 14, they might go for some other options like oral appliances. But for all practical purposes in India, dentists are not giving us, providing the oral appliances which are needed. And surgeries are also very, ENT surgeries are also very rare. So anybody, even with a mild OSA, if they happen to have excessive daytime sleepiness, they should go for PAP therapy. Surgical options are available. I'm not going to discuss them. But the problem with surgical options that do not abolish or bring down AHI to the normal. Those who have got severe OSA, their AHI will reduce, but they won't be able to bring down to normal. And these are major surgeries technically very demanding surgeries. So one has to be very cautious before going for surgery. The surgery should be offered to only those patients who deny CPAP for some reason. They are very averse to use CPAP. Now we will talk a bit about obesity hyperventilation syndrome. Now, obesity hyperventilation syndrome is defined by morbid obesity, chronic hyperventilation, and hypercapnia. And the cutoff for PCO2 is 45 mmHg during wakefulness. Characteristic finding observed including awake resting hypoxemia, hypersomnolence, sign of cor pulmonale, that is right-sided heart failure, pedal edema, and nocturnal hypoventilation. Diagnosis of OHS require demonstration of at least 10 mmHg increment in PCO2 during sleep. So up to 5-6 mmHg of increment is normal during sleep. Anybody who's having, in order to say that patient is having hypoventilation, we have to document that compared to awake, during sleep, there is a rise in PCO2 value of more than 10 mmHg. So once again, patients should have daytime hypercapnia, that is PCO2 of more than 45. BMI should be more than 30. Should not have any other lung disease. Suspect OHS if BICAV is more than 27, which is kind of compensation for respiratory acidosis. this disease has got high mortality if remains untreated. Almost 80 to 90% of OHS patients would have OSA. These patients will also develop severe nocturnal desaturation. Almost all of them will have sleep-related hyperventilation, that is rise in PCO2 more than 10 mmHg during sleep, and they will develop severe carbonyl and pulmonary hypertension. And if not treated, has got a very bad prognosis. Another entity where hyperventilation may take place is, I just wanted to stress upon to audiences that OSA itself will not cause hypercapnia because patient is able to ventilate between the interapneic period. So if patient is having hypercapnia, you cannot say that this hypercapnia is because of OSA. OSA patient develop hypercapnia in presence of two things. Either they have obesity hypoventilation or they have a COPD along with it. So that you must remember. Now, COPD and OSA both are very common condition, and sometimes they coexist, and these patients will develop hypercapnia. These patients will develop severe and prolonged oxygen desaturation. They will be at a higher risk of cardiovascular disease. And their reservation will be more common, and they will develop severe pulmonary hypertension. And to treat this patient and treat even OHS patient, anybody who has got hypercapnia, CPAP will not be effective. Here you have to go for bilevel ventilation. So that's all from my side. DP Singh sir, can you come in, sir? Sir, you asked for 4 questions. So I thought I will just put up these 4 questions, sir. So would you like to ask, go for it, sir, or should I read it out?
First, answer Dr. Shakit's questions of Dr. Shakit, and then your question, Dr. Neha, he will answer your questions.
So the question is, of the following, what is the best documented risk factor for OSA? Cigarette smoking, alcohol consumption, postmenopausal status, obesity.
Dr. Shakit, they have answered some questions. Just
So I'm not able to see the responses, sir. So you have to tell, sir. I'm not able to see the response. So shall I go with the answer, sir?
yeah.
So you see, all 4 of them are a risk factor for OSA. But among all these, if you have to choose one, it has to be obesity. Obesity is probably the most important risk factor. We have seen that as the patient will gain weight, the risk of OSA will go up. It's particularly higher in those who have BMI more than 30. And with weight reduction, there is a decrease in AHI. So among all this, this was the easy one. But here it will be, you have to use what have been told. So the question number 2 is, which of the following group of patient will be the good candidate for portable monitoring? So we have got different kind of PSG testing. So who are the patient who are good candidate for, among these 4, good candidate for portable monitoring? Option A is those who have snoring, witnessed apnea, daytime sleepiness, and hypertension. Option B is snoring, witnessed apnea, congestive heart failure, and daytime sleepiness. Option C is snoring, no witnessed apnea, non-restorative sleep, no daytime sleepiness. And option D is snoring, daytime sleepiness, and neuromuscular disorder. So among these 4 kind of patient, which patient is good candidate for portable sleep testing or home sleep testing? Please come with the answer. Chat box. Shall I go ahead and tell, sir?
Yes, yes.
So this is very important question. Because we have access to the level 3 studies mostly. So who should be subjected to level 3, who should not be subjected to level 3? So option D is patient has snoring, patient has daytime sleepiness, but patient has neuromuscular disorder. Now, because of this comorbidity, we do not know if we will have hypoventilation, which a level 3 study cannot pick. This patient should be subjected to level 1. Option C is, so he is not a suitable option D is not a suitable patient for home monitoring. Option C is patient has snoring, no witnessed apnea. He does have non-restorative sleep, but he does not have daytime sleepiness. So what does it mean? That he does not have witnessed apnea, he does not have excessive daytime sleepiness. So the pretest probability of having OSA is less. Now, patient who does not have a high pretest probability of OSA, he should not be subjected to home monitoring. He should be subjected to level 1. Option B is snoring, witnessed apnea, daytime sleepiness, but he happens to have congestive heart failure. And because of congestive heart failure, he might have various kind of sleep breathing disorder, including central sleep apnea, including
किस
chain stroke
पोजीशन में
breathing.
ठीक रह रहा है?
So this patient
वैसे
again is
नहीं।
not suitable patient for home monitoring. The patient who is suitable for home monitoring is patient number A. He has snoring, he has witnessed apnea, he has daytime sleepiness, and he has hypertension. So he has high pretest probability and he does not have any comorbidity which would interfere with the home testing. So option A is the correct answer. And this is the patient who's supposed to go for home test monitoring. So message is high pretest probability and no significant comorbidity to do a level 3 sleep study. Now, option 3 is again straightforward. Question 3, sorry. What is the approximate prevalence of OSA defined as AHI more than 5 associated with symptom? So it is option B, in women 2%, men 4%. And I'll go with for question 4, which I would request people to try. Which of the following is always true about patient with obstructive sleep apnea? Option A is daytime PCO2 more than 45 mmHg, BMI more than 30, worsening PCO2 and PO2 with sleep, AHI more than 5. So, which is not correct among these 4 options? Please try. Response from the audience, sir. So I will go ahead and answer this. So option A is correct. Option B is correct. Option C is correct, that they would have worsening in PCO2 during sleep more than 10 mmHg. Option D is not correct. Now, why it is not correct? Almost 80% patient of obesity hypoventilation will have OSA, but 20% may not have OS and yet have hypoventilation. So see this. Obesity hypoventilation, 80% patient will have concomitant OSA. But 20% patient will have normal, they will have no obstructive apnea. It's simply because of abdominal, because of excessive weight, there is so much loading on the respiratory muscle that respiratory muscles are not able to cope up. And they do not have any upper airway obstruction. They are not able to breathe enough to sustain the normal PCO2, and their PCO2 will go up during sleep. So option D is the correct one. So that's all, sir. That's all from my side, sir. I think this was the last slide.
Answer some of the questions they have put.
Sir, I'm not able to see, sir. I'm not able to see. In chat box, sir.
Yes, genetic predisposition of OSA, family history important or not? Association between metabolic syndrome and OSA.
Sir.
Screening tools in no EDS, OSA without excessive daytime sickness. So these are the 4 questions. Effectivity of recent approved drug, tirzepatide. That is on the chat box.
Sir. So first coming to this tirzepatide, that is GLP-1 drug. The thing is that they are going to cause weight reduction. And weight reduction, they have been introduced recently. We do not know what will happen in long run. They have been approved for OSA. And probably the mechanism of action is going to be they will cause weight reduction, and because of weight reduction, the AHI will come down. Now, we don't know about these drugs, what will happen in long run. That we have to see. But we do have a similar analogy in form of bariatric surgery.
Dr. Shakit, please be brief. We have already overshooted our time.
Sir. So bariatric surgery is in place since last 20, 30 years. And what we have seen that these patients will lose weight following bariatric surgery. Their AHI would come down to some extent, but they will develop, even if they are not gaining weight again, they will develop worsening in AHI once more. So this drug has to be, it's been approved. We have kind of excitement for this drug, but in long run, how it's going to behave, and how effective it's going to be, only time will tell. So it's been approved, but it has to prove its mettle in due course of time. A screening tool for EDS-OSA, no EDS-OSA. So you have got burden questionnaire and the stop bank. So these two tools we are using as a screening, but at the same time, no tool is absolutely sensitive and specific. So if you have a high suspicion, if patient gives history of witnessed apnea, even though if he's not feeling, doesn't have EDS, you should go ahead and test. So stop bank and burden questionnaires are 2 tools which you can use even in those patients who are not having EDS. It will give you probability of OSA, but any screening tool is not a replacement for polysomnography and objective testing. Association between metabolic syndrome and OSA. Most of these patients are obese and they do have metabolic syndrome. They do have insulin resistance. Let's see. Metabolic syndrome, obesity, and OSA, everything goes together. OSA patient, sleep deprivation and weight gain is it goes together. We have got these 2 hormones which we don't talk about very often. We have got this hormone leptin, which is satiety hormone, secreted by adipose tissue. And then we have got this hormone ghrelin, which is hunger hormone, secreted by mucosa in the stomach. Now, what happens when you are sleep deprived? You tend to eat more. And there is a increased secretion of ghrelin and decreased secretion of leptin resistance. And people tend to eat more. They used to gain weight. So metabolic syndrome and OSA, obviously, it goes together. They go hand to hand. Metabolic syndrome, obesity, OSA, insulin resistance, everything goes together. And sleep deprivation is one of the reasons of overall society getting fatter. Genetic predisposition for OSA, family history is important. Many of the craniofacial structure are genetically inherited. Somebody whose father has got small, in family, if you have got a small jaw, then you are going to have a small upper airway, which will tend to collapse. So many of these craniofacial characteristics the tones of dilated muscles like genioglossus, palatoglossus are genetically inherited, and family history is pretty important. If you have obesity over that, it will further add to the insult. But I think people do have this craniofacial characteristics are very strongly inherited, and if certain abnormalities are running in the family, it will manifest as OSA. Is there anything else, sir?
There are two more questions. OSA patient already on pulmonary hypertension, developed pulmonary hypertension. What could be the management of the patients and mortality? Just give one line treatment. You should not go in detail.
So OSA, if somebody is developing pulmonary hypertension secondary to OSA, it's a group 3 pulmonary hypertension. Now here you do not use any pulmonary vasodilator that will be detrimental to the patient. You have to treat OSA, and when you treat OSA adequately, maybe over the period of time, pulmonary hypertension may reverse. So what I mean to say that if it is group 3 pulmonary hypertension secondary to OSA, pulmonary vasodilators are not indicated. You have to address OSA or any disease which is precipitating it. If it is hypoxia, correct hypoxia, like that. So,
that is our chairman, Dr. P.K. Agarwal.
sir,
Okay.
brilliant, sir.
And again, the NEHA, that's intermittent CPAP, whenever the patient goes out of the town. So we have to carry on with this CPAP machine with you whenever you go
Yes,
out
sir.
of the
Yes,
town,
sir.
and you have to take this.
Yes, sir.
That's a very nice questions. Dr. Neha always put up questions frequently in all the sessions. Thank you, everybody. And that is the wonderful deliberation by our Dr. Shakesh Sharma, and he has adequately dealt with a fantastic, comprehensive talk on sleep disorder breathing, and especially covering the whole gamut, 7 types and other things, and focusing on the OSA that is uh, as a life-threatening conditions, and millions of the people over the world, they are suffering. But the awareness about the problems and the gravity of the situation, the consequences, whether it is cardiovascular complications, consequences, metabolic consequences, even leading to the mortality, increased mortality. This resistant hypertension, very often we get because of this OSA. And as you know, there's obesity is the mother of more than 50 disorders. One of these disorders is the OSA. And so the awareness is very much important. And we call all friends who are listening, all healthcare professionals, that we should be aware of this situation, do the early diagnosis, and manage as per the guideline. Thank you very much. And next Wednesday, we are meeting again, same time, 7:30 to 8:30. And the speaker will be Dr. Surjikant from Lucknow. And that topic will be drug-resistant tuberculosis. Thank you very much. Good night.
Thank you, sir. Thank you, sir. Good night, sir.
Thank you, Dr. Saket, and all the listeners.
Thank you.